In this video I'm going to show you the best shoulder impingement exercises in the year 2021 and beyond. And as always, don't forget to subscribe using the button below for exclusive first access on content that's going to help you become the go-to therapist that gets results, reviews, referrals and that reputation to build a go-to clinic. Now if you don't know me, my name is David Sullivan. I've worked in professional sport for over 13 years and everything I share with you is exactly what we use in the real world, both in a professional sport environment and also private practice, to bridge the gap from the low level to the high level rehab so you can get the results, the reviews, the referrals and that reputation. So in regards the best shoulder impingement exercise, well, first off, this term shoulder impingement, the literature is suggesting that we probably shouldn't be saying the word impingement anymore, although let's be honest, everyone still uses it. It's going to take a while to change. So that's the first thing we want to be aware of, is that this idea initially of, the shoulder as it comes up, that the rotator cuff impinges. We actually can see now that there's probably going to be more to it than that it's not just a structural problem. And the key thing is that we understand that actually pain is multifactorial. So that is actually good news for our patients. It's not necessarily bad news, because it means that there's a lot of things we can do to change the pain experience. And from working in professional sport for over 13 years, I have seen a lot of shoulders that have looked very good on MRI scans and clinically they were poor, and vice versa. Clinically, they were really good. MRI scans showed a lot of wear and tear, and then also clinically they were really poor, but actually the MRIs were really good. So that's good news for us as therapists, because it means that we can change things even if there is potential damage. That doesn't necessarily mean the patient has to have a pain experience. So this concept of pain is multifactorial, then let's get to it. So what we want to look at, and our strategy is to work smarter, not harder. So let's still respect pathology. If there is pathology present, let's still respect the symptoms, but let's spend 80% of our time getting everything else doing its job to ultimately show the nervous system that it's safe to tolerate load. And if we look at this like in an iceberg, okay, this is what the patient is saying and doing and feeling and moving, but we have to respect the nervous system underneath. And the nervous system is giving us this conscious experience of non-pleasant sensation. So we have to ask ourselves, what can we do to ultimately change that experience? Okay, and there's actually plenty that we can do. So the first thing we want to do is want to look as that shoulder starts to come up, rather than looking here at this point where they usually start to get pain. It's what else needs to do its job at this point of the movement. Okay, now the first thing I want you to notice here is that there's a lot of other things going to be involved in this. Okay, so as that arm goes overhead, I want you to appreciate the importance of the long head of triceps, the serratus and the biceps. So if we start and we look at the triceps, we can see that it attaches at the scapula. Okay, so again, whether you are a therapist that wants to look at scap stability, etc., you have to understand that we need that long head of triceps to lengthen. So if we look at muscle of motion here, you could see that long head of triceps needs to lengthen as it attaches to the scap. Okay, so again, one of our big approaches here is, is that long-headed triceps able to lengthen? Okay, so that's going to be one of our approaches in our multifactorial approach. Okay, so one of the 80% is, let's get that long head of triceps and ability to tolerate load. The next thing we need to be looking at here is the biceps. Okay, so again, the biceps, long-headed biceps, we know obviously it's going to insert around that labrum as well. That could also be an area where a lot of patients will say, yeah, I just feel it here, or sometimes they'll say that it runs down the arm. But what I want you to be really aware of is that when we internally rotate the shoulder, we need that long head of triceps, the biceps, we need that biceps to lengthen. Okay, so as we internally rotate, we kind of go into these inverted commas impingement positions. You can see that long head of biceps, it needs to lengthen here. Okay, so that's going to be another big part of our approach, is let's get that long head of biceps to tolerate load, but also to go through a full range of motion. Okay, so we've got triceps, biceps. Okay, and then the last thing I want you to understand is the importance of ribcage mobility. Okay, so again, you can see here This might be an apprehension test for a lot of people. They may not like these positions, but what I want you to notice is the amount of tissues that have to lengthen. So obviously, the pecs need to lengthen, but what I want you to pay particular attention to is that rib cage mobility, and in particular, the ability of serratus anterior to lengthen. Okay, so with serratus anterior, if we go in and have a look at serratus anterior, so this is the traditional kind of motion, okay, where we move our arms. But what I want you to look at is the importance of when the arms are fixed, is that rib cage protraction. Okay, so that rib cage coming forward, okay, we need that serratus to lengthen. And look at the size of that muscle, okay, so we want good rib cage mobility. In order to have that, we want good serratus anterior lengthening. So you could see all of these movements that potentially might be uncomfortable. Even here, I want you to look at the ability of that long head of biceps to lengthen. Okay, pecs obviously lengthen, but the rib cage protracts. And what you're not seeing here from this great animation from Muscle Motion is that serratus anterior is lengthening in this position. Okay, so the serratus anterior needs to lengthen. Okay, the rib cage needs to protract and come forward. Okay, and that's going to be a very important motion for a lot of everyday functional positions. Okay, so again, as I go to reach overhead, etc., I need that rib cage mobility. I need the clavicle to mobilize as well. Okay, so the approach for us is, right, let's respect the symptoms, but let's get everything else doing its job, because in the real world tasks, all of our intention or intent to move, it all starts at the hand usually. Okay, so our intent to move, okay, I'm going to pick something up. The first thing I do is I'm going to reach with my fingertips usually. Okay, my fingertips are going to drive a lot of the reactions that happen, and then ultimately I want my hand, my elbow joint, my shoulder, my pec, everything to do its job. Okay, so again, if we look at the ideal scenario, what's the end goal? We want the ability to tolerate load in all of these areas. Okay, but again, for somebody, and again, this is just for teaching purposes, this probably isn't 100% accurate, but you can see we might hypothesize that somebody that has the shoulder pain experience, that the nervous system might be saying, okay, I'm not very happy here, I'm probably doing a lot of work. Okay, so again, we have to ask the question, why is this area grumpy? Why is the nervous system sending this person a conscious experience of either an unpleasant sensation, a pain experience, whatever symptoms that they are feeling? Okay, so our approach is, right, let's get everything doing its job. And again, this might be 100% accurate for every patient. Again, you have to use your assessment, and that's where in the mentorship, we show you exactly how to look at the body as a whole. We look at the body as one without getting overwhelmed. Okay, but the key thing is, let's go from here to here and let's get everything doing its job. And from 13 years of working with some of the trickiest, most complex shoulder cases in the musculoskeletal system, what I've noticed is that once we get everything else doing its job, very often that pain experience settles down, and very often that painful and weak rotator cuff actually increases its strength miraculously, which makes me believe that it's not a strength issue, it's actually a coordination issue, and it's a nervous system issue. So if we can get that to settle down, then usually the patient does very well. So what we need to do is we need to do this in a gradually exposed manner. So just because you get somebody pain-free in the clinic and they bring their hands overhead doesn't necessarily mean they're ready to tolerate the levels of load and the speed of movement that the real world has to offer. So that's where we have to bridge the gap from the low level to the high level rehab. Okay, and not only that, we need the patient to not only be pain-free, but to move with thoughtless, fearless movement, because it's such a big difference between getting somebody pain-free and somebody having the confidence to go out and move with thoughtless, fearless movement, like Louis Gifford says. So in my career, I've sent athletes back where clinically they had no pain and they were fine, but I could see that they just were not moving with thoughtless, fearless movement. Their confidence just wasn't quite right, and in some cases it's bit me in the ass, and I've made mistakes. Okay, so that's the importance of, just because somebody's pain-free, that's not the end goal. The end goal is to get them to move with confidence. And ultimately, a lot of patients, they'll spend a lot of their time where they'll be doing top-down cues, where they'll be actively recruiting the rotator cuff or trying to isolate the traps or something like that. Real life doesn't happen like that. Real life, we have to be able to move with the fingertips, and the rest of the body has to react. And as I said, a lot of patients, they're never taken to the point where we transition from top-down active cues to being able to use these muscles outside of higher center control. But ultimately, this is where the magic happens, and this is where confidence and self-belief in our patients' bodies resume. Okay, so we need to take our patients not only from these nice, safe exercises in the treatment room, but we need to bridge that gap back to real life. Okay, so before we go into the actual how to do this, just pop a comment. So in the comments, is this making sense so far? Because again, what I want you to do is I want you to understand this information, and I want you to be able to apply it in the real world to get results, to get reviews, to get referrals, get that reputation as the go-to therapist, and build a team of go-to therapists that ultimately have a go-to clinic reputation. So not only that, pop a yes in the comments, and then followed by your biggest takeaways so far, so that I know that you're understanding this. And as always, thank you. I want to give a special mention to Muscle Emotion. Great resource. Anytime I have a tricky patient, I go into Muscle Emotion, I look at the anatomy, and I go, what else has to do with this job? What am I missing? And if you want a special voucher code, they've kindly agreed for our subscribers. If you type in PSP20 at the end, I usually go for the strength training app myself personally. If you type that in, you will get a 20% discount. Okay, so back to it. So what's the approach? So yeah, you might spend some time with your rotator cuff exercises. I'm not saying forget about the rotator cuff, but what I am saying is let's get everything else doing its job as well. So the approach is, yeah, let's settle down the symptoms, okay, but let's also look at what else isn't doing its job. Let's restore range of motion, let's restore the ability to tolerate load, and then let's see what's left over. And very, very often the pain experience settles down and the person moves back to thoughtless, fearless movement. Okay, so the first thing we want to do is we want to make sure that we have good range of movement. We have restored an ability, if you want to go back to homeostasis, whatever wording you want to call it, want to restore the ability to go through a full physiological range of motion that the nervous system should have access to. And if we have a decreased range of motion, we have to ask ourselves why. Okay, and very often that's what we would call maybe protective tone, for want of a better word, okay, where the nervous system puts down these reactive strategies, and it's not necessarily scar tissue or anything like that. So we can very easily change these joint range of motion very quickly with the right stimulus. Okay, and again, that's what we teach in the mentorship in module 3. Again, it depends on the assessment specific to your patient. A lot of that will be found in the subjective story. What's in the story that's ultimately stopping them from being here to get to there? What happened in the story that caused them from being here to ultimately go to there? So you'll have to have that specific to your patient, and it all starts with pillar 1 in the subjective. So what we want to do then is we want to get the first thing we may want to do is we can shortcut the time it takes to get this. And again, in the assessments, in the mentorship assessments, we can put load through these tissues at submaximal levels of load tolerance, and we can find the directions maybe that they're not tolerating load very well, or we can certainly hypothesize that they're not tolerating load very well. So again, is it they're not tolerating load well through the bicep, through the tricep, or whatever it is, and that can give us clues so that we're not trying to do everything. But for the purposes of this video and blog, we will have a look at this. So if we want to lengthen the biceps and the pecs, we're just going to have a look at some movements like this.
Now this is obviously going to put your shoulder in a slightly different position.
Okay, so all we're doing here is we're getting the reaction. So Shade is rotating here. You can see his hand pressures as well. He's putting his load into his index finger, which is going to drive that reaction through the long head of biceps and also the pecs. So we're getting that lengthening ability through all of these tissues. Now, as you'll notice on the graded exposure ladder, okay, range of motion is one thing. What we need to do next then with that is we need to get some load tolerance through it. Okay, so the next thing we're going to do is we're going to put the biceps in a position where they've got no choice. The nervous system has no choice but to tolerate load, because for working in sport for 13 years, I've seen that especially even the strongest athletes, they are great at cheating. They're great at finding ways to avoid loading these tissues. So what we want to do is we want to work smarter, not harder. We want to put the person in a position where they have no choice but to tolerate load. Okay, so all we're going to do here is we're going to challenge our base of support. We're going to make sure that our belly button's over our toes, and then we're going to put load through all of these tissues. So again, we're starting out the transition from the top down to bottom up. So a lot of these movements, we're just focusing on the fingertips, but we're getting reactions through the long-headed biceps, the deltoid, the shoulder, and everything else. And then the next thing we want to do as we start to move back to speeds of movement, it's not just about being able to tolerate load, it's about being able to tolerate load at high speeds of movement as well. Okay, and usually the higher the speed of movement, the less load we're tolerating. Usually that's real life. Okay, so again, speed of movement, load are something that we want to look at. Okay, so again, with these kind of exercises here, the key thing here is that
once I get above my right chest,
just going to pop this down for you.
Then I'm going to start to rotate. Okay, now
okay, so you might use an option like this.
So I might want to just have a little bit of tension on the band at the start. Keep my head down, and I'm just going to rotate.
Now the key thing here is I rotate, and my finger comes down to the floor. So you can see the importance of that long head of biceps and the biceps in general to lengthen here. Okay, so again, we're getting everything. If we put that up again, we're getting everything to do its job. Okay, so if I think it's this one here, if you bear with me, the biceps had to be the last one. Okay, so again, we really want to encourage that biceps to lengthen. Okay, and again, we want everything to do its job here, because again, the pecs, the shoulder, the clavicle, rib cage, everything needs to be able to do its job. Okay, so that's another option that we're going to do, and then as we start to do that, we can really start to increase the speed of the movement throughout the movement. Okay, so again, if you have somebody that has to reach across their body throughout the day, we want them to be able to do this with thoughtless, fearless movement. So we're starting to increase the graded exposure to these positions that they might need to reach. If they need to reach for in a tackle or something like that, we're showing the nervous system it's safe to tolerate load. Okay, so the next thing we want to do is, again, you could shortcut the time it takes to do this, so you don't have to do all of these exercises. A very clear understanding of the assessment, the patient's story, then making sense of the objective assessment, explaining the findings to the patient, and then taking them through a graded exposure will save you a lot of time. Okay, but just to show you some other examples, some tricep lengthening, again, just helping that tricep to get some length. So again, we can take off the symptoms very, very easily usually when we get everything else doing its job. So Shay's just getting some tricep lengthening there. Then same concept again, let's put some load through the tissues. Let's give the nervous system no choice but to tolerate load. And in this position here, all I'm going to do, same thing, challenge my base of support, create perturbations, cause the long head of triceps to tolerate load. Okay, in that exercise, then what increase the speed of movement. Okay, so if we get that here, again, we're getting good core contractions at the elbow, and there's a lot of loading at the wrist with these movements. Okay, so the key thing here is that we build tension through the fingertips, and we're starting to increase the speed of movement. So again, very, very different to the other exercise. The other exercise is more focused on load tolerance. This is more focused on speed of movement. And then the final thing, which we've obviously spoke a lot about, is the importance of that rib cage to be able to mobilize. So then we're going to go to some kind of serratus anterior stretch or something like that, where we're basically going to protract the rib cage, and then we're just going to mobilize it in the frontal and the transverse plane as well. So in this exercise here, we're actually stretching our left serratus anterior, so rib cage protraction, and then a bit of side flexion as well. Okay, and again, I'll put all of these videos as single videos on our Instagram page as well for you, so that you can check those out. Okay, so what you'll see is that we're starting to work our way up, but we still have a long way to go. So just because our patient symptoms are starting to ease here, and the symptom, they're starting to move well, again, we need to make sure that they're prepared for the end goal. We want to take the emotion out of it, so that we understand exactly where we want to go to. We want to bridge that gap from the low level to the high level rehab, because usually session 3 or 4, they're progressing well, but it's the ability then to keep that progress when the hands-on treatment isn't maybe as effective anymore. You might have done some stuff in your hands-on the first few sessions, they'll respond really well to it, but to keep those gains and to keep the patient progressing, you're going to need a lot more than hands-on treatment. You're going to need that graded exposure to bridge the gap. So as always, when you do an exercise, have a couple of KPIs, retest your KPIs to make sure that the nervous system is liking it and it's not going backwards or showing some negative reactions. And then, as I said, we just go through all the steps to get the patient back to tallest, fairest movement. And that's where you need more than just hands-on treatment, or you need more than 1 or 2 rotator cuff exercises. You need to have the full package as that go-to therapist. You need to make sense of the story, make sense of what you're seeing in front of you, the objective, effectively explain the problem and the solution to the patient, get them a bespoke treatment plan that gets them back to where they want to get to, not just some generic exercises. You have to problem solve. You need to be very good with your hands where you can actually get results but without relying on your hands. And then you need to recreate the feeling that the patient gets from your hands-on treatment with your rehab exercises. You need to bridge the gap from the low level to the high level. And then also, not only that, but we want to build strength and we want to build resilience. Okay, so if you want more information, head over to www.thegotofysio.com/free, and you can have 14 days free access to my shoulder return to play course. And in that, I will show you how to bridge the gap from the low level to the high level rehab, absolutely free of charge for 14 days. I'll also show you some of the cuff variations that I use, how we integrate the fingertips with the rotated cuff, and there's also a 53-page manual. Okay, so if that makes sense, if you've any questions, pop your comments below. Make sure that this is all making sense to you. Make sure that you enjoy this content. If you find this content useful, then I'm more than happy to make more and more content along these lines. Okay, so head over now to www.thegotofysio.com/free. Claim your 14 days free access to the shoulder return to play course, and make sure you comment below, and I will see you in the next video if you find this content useful.